Hi, everyone, and welcome to this WHO and TechNet 21 webinar series on life course and integration. This is our third session, and today we'll focus on catch-up vaccination and ongoing safety net to reduce immunity gaps across the life course. You can listen to this presentation in French. To do so, please select the globe at the bottom of the Zoom window and choose the desired language. If you struggle with it, to find it, just let me know in the chat area. Also, there will be part of this presentation that will be done in French, in which case you need also to go to the English channel if you want to listen to this session in English. I'm going to say that in French for the francophones. Vous pouvez écouter cette présentation en français. Pour cela, allez cliquer sur le globe qui se trouve en bas de votre écran et choisissez la langue française. Vous pouvez rester là et toute la session en français sera disponible là. Talking about the chat box, if you have any issue, like technical issue, just let me know and I'll try to help you as much as I can. You can also start introducing yourself because, well, we're very happy to know who's with us. And so don't hesitate to tell us where you are and who you are. If you have any question during this presentation, please use the Q&A box, which is also available at the bottom of your Zoom window. So click on it and ask your questions at any time. They will be answered after the presentation during the Q&A session. Finally, this session is recorded and we'll share with you the links to the video as well as the slides later this week or early next week. I hope you'll enjoy this session, and I'll give the floor to Stephanie.
Thank you, Alex. So we have a very dynamic session to offer today with a lot of really interesting speakers. I will start off with a brief overview from the global perspective. For those who don't know me, I'm Stephanie Schendale. I am a technical officer in the life course and integration team within the expanded program on immunization at WHO in Geneva. We also have a number of colleagues from the Federal Ministry of Health and Ethiopia on the line with us today, Dr. Mezarid Salalem, Melkamu Ayalu, Kibrom Abraham, and John Leku, and they will be presenting Ethiopia's experience with a recent catch-up policy that's been implemented. And finally, we will have a presentation from our colleagues from Cote d'Ivoire. We have Dr. Kone Fatoumata from the EPI program in Cote d'Ivoire. We have Serafin Kouassi from JPIGO in Cote d'Ivoire, and we have CA Cabran from the WHO OMS office in Cote d'Ivoire. So a lot of interesting information coming your way today. So I'll just kick it off. Next slide, please, Alex. And you can go straight into the next one. So the title of today's webinar is Catch Up as an Ongoing Safety Net. And I just want to start by getting us all on the same page about what we mean by catch-up vaccination. Those of us who work in the immunization space can refer to catch-up campaigns or sometimes multi-age catch-up when we're introducing a new vaccine, but actually providing catch-up opportunities through the routine service delivery is and should be an essential component of all routine immunization programs. People miss vaccination for many reasons, we know this, but no one should miss out on vaccination completely just because they aren't able to access services in time. So any opportunity to vaccinate an individual who's missing a dose for which they're still eligible, this is a catch-up opportunity. And there's a lot of emphasis on catch-up right now, as many programs experience disruptions in service over the last few years due to the pandemic. And so if catch-up's not already an established policy and practice, now really is the time to be thinking about this and putting these systems in place. Next slide, please. So just the same as people miss vaccines for many reasons, many programs are also missing opportunities to catch up for many reasons. For those on the line today who have worked in the missed opportunities for vaccination space, you'll probably be very familiar with a lot of these barriers that have been identified in many settings and over the years. And so, for example, a lack of policy for catch-up vaccination, Sometimes it's due to lack of health worker understanding around the schedules for late or delayed vaccination. And we know in a lot of places there still are strict upper age limits, cutoffs for catch-up vaccines, which means that sometimes children are missing the opportunity to be able to get vaccines for which they can still very much benefit from protection. This can obviously lead to issues with equity. And as I said already, no one should miss out on the right to vaccination simply because they've arrived late. Integrating services and offering catch-up vaccination opportunities across the life course can help identify and address some of these barriers. Next slide, please. So WHO has published recommendations and implementation guidance for catch-up vaccination. The guidance document on the left-hand side here, Leave No One Behind, is an implementation guide that outlines key policy and programmatic considerations for implementing catch-up vaccination across all aspects of the immunization program, and the importance of really thinking about this as a whole systems approach. So we'll talk more about that later on. But of course, this starts with establishing, where it doesn't already exist, a catch-up vaccination policy and schedule. Alex, if you can just click, and you can click twice, there's a little animation, and then the next slide. Next slide. So a catch-up vaccination policy, and this might be part of an EPI policy, or it could be a standalone guidance in some settings, but the main message is that it should provide clarity for the health workers, those who are actually responsible for implementing catch-up vaccination. This is where it's important that the policy provides clarity on, well, re-emphasizing the importance that vaccinations are still due to these children and individuals, even though they've missed one or more doses within the EPI schedule. It should provide really clear guidance on how to determine eligibility, including those age ranges that are still permissible for vaccination, and also very importantly, what to do if vaccination history cannot be confirmed. So if there isn't a home-based record or some sort of record that shows which vaccines an individual already has, what should the health worker do? This is important to have that clarity in the guidance. Also, the policy should outline how to correctly record and report delayed doses if they're provided above the age of a recommendation. And of course, leveraging every health contact as an opportunity to check vaccination history and catch up on vaccinations as appropriate. Next slide, please. And all countries should also have a catch-up schedule based on their national immunization schedule that, again, provides clear instructions to a health worker or anyone else who's tasked with determining eligibility, which age cohorts the catch-up schedule applies to, the minimum age, and if applicable, the maximum age per national policy. And very, very importantly, clear directives on the minimal intervals permissible between each dose, because if an individual starts a vaccination series late, then they may have to have it as an accelerated schedule. And then it's really important to make sure that the health worker is clear on how many weeks need to be between each dose so that they can instruct the individual or the parent as to when to come back for the subsequent doses in the series. As immunization programs expand across a life course, multiple catch-up schedules for different target populations or age groups will be needed. Next slide, please. So, and you can click twice, Alex. If you guys can just share in the chat, we don't have time for an official poll, but it would be really interesting to hear for those who are participating. Does your country have an official written catch-up vaccination policy? And does your country have a catch-up vaccination schedule? You can please just put that in the chat. We'll be really interested to hear. Next slide. So for those on the call who are not familiar, every year there is an annual joint reporting forum, WHO and UNICEF annual joint reporting forum. It's called the EJRF, which asks countries to provide information about all aspects of the immunization program. And on this reporting forum, we ask if countries have a catch-up policy in place within their national immunization policy, and if they have a catch-up schedule for interrupted or delayed doses. And these are the results from the 2021 survey. And as you can see, a large amount of countries do have in place a catch-up policy, but only about 50%, less than 50% of member states have a catch-up schedule. And then even fewer actually provided a copy of the schedule because we asked for that as well. Next slide, please, Alex. And so of the countries that provided us their schedule, we had 57 catch-up schedules that we were able to analyze and to see what age ranges are permitted for catch-up vaccination within these schedules. And we looked at them broken down, those who only allow catch-up up to 2 years, only up to 5 years, and those who provide at least one vaccine can be caught up above 5 years of age. So this might be measles that doesn't have any upper age limit. Anyone who hasn't had a measles vaccination should get 2 doses of measles. So 45 of these schedules do provide at least one vaccination opportunity beyond 5 years. Next slide, or click, please. However, I do need to point out that of the schedules that we've received for analysis, the majority of them, the vast majority of them, are still coming from high and to a certain degree middle-income countries. We have very few examples of catch-up schedules in place in low-income countries. So we do know that this is still a gap, an area that needs additional work. Next slide, please. And so not only is there obviously room for growth in this area, but it's also not only about just having the policy on paper. In order to really have catch-up vaccination in place as a safety net, we really need to look at this, as I said earlier, as a whole system approach. And so Alex, if you can just click a few times, the slide is animated. I don't unfortunately have enough time to spend in detail on all of these pieces, but I do want to direct you to the guidance that was mentioned earlier that goes into a lot more detail around each element of this across the wheel, from ensuring agility in vaccine forecasting mechanisms, modifying data systems and tools. Alex, if you can just click through, please. There's a bunch of things that should be showing up. Yes, thanks. Building the health worker knowledge and practice to deliver the catch-up vaccination, understanding, as I mentioned earlier, the schedules and how to communicate that to the patients and parents. The communications aspect, making sure that communities are aware that just because they've missed their window, they can still come back for vaccination opportunities later. And then finally, making sure that all those opportunities for touch points along the life course are built into the program to enable opportunities for catch-up. So there's a few more things to click through. Sorry, Alex. And one more. And so, as I said, unfortunately, we don't have enough time to go through all of these, but they're covered in a lot more detail in that guidance document. And then finally, last slide, please. I just want to add that, as I said at the beginning, there's a lot of emphasis on catch-up right now because we know that there have been some significant program disruptions in the last few years as a result of the pandemic. And so while there is absolutely a need to urgently close some of these immunity gaps, recover immunization coverage, and prevent impending vaccine-preventable disease outbreaks, it will be a real missed opportunity if the emphasis is only on the short-term solutions. We have the increased attention, we have funding opportunities with COVID-19 recovery funds, opportunities for expanding across the life course. And this is really an opportunity to make these investments and key changes in the system to set programs up for a long-term, robust catch-up vaccination platform. So this slide just sort of shows the dichotomy here and how we really need to bring both sides of this together to make sure that we're building better systems to enable programs to withstand any future shocks or interruptions to services that may result from additional interruptions in the future. And I think that's the next slide. If you can just click, the next one is just a resource slide. You'll have these slides available to you afterwards, but all of these resources from WHO are available in both French and English, and in many cases, additional languages. And this will all be available to you in the slide deck afterwards. But I don't want to take up too much time because I want to make sure we have opportunity to hear from our country colleagues. So I'll end there for now and looking forward to the discussion at the end of the call. Thank you. And if you can just go to the next slide, we have Ethiopia, and I will turn the microphone over to Melkamu and Kibron to take us through Ethiopia's experience. Thank you so much.
Okay, thank you, Stephen. I am Melkamu Ayaleo from Ministry of Health API Manager. So today I'm here just to share you Ethiopia's experience on catch-up vaccination policy and its practices. And also, I hope I will learn from other countries. Thank you. Next slide, please. Okay, I will give you first background information on the Ethiopian immunization and general information, and then jump to the catch-up vaccination policy and practices and the challenges and the next steps that we have. Next slide. Okay, just to give you some information about Ethiopia, it has a total population of 107 million and administratively divided into 11 regions and 2 sub-city administrations and subdivided into zones and waradas. And most of the population lives in a rural area. And Ethiopia is a big country covering 1.1 million square kilometers. When you come to the health infrastructures, there are about 408 hospitals and about 4,000 health centers and near to 18,000 health posts. Next slide. This is also to show you the health operating health infrastructure and structure. We have a third tier system, primary level healthcare, secondary level, and tertiary level, in which all of them are providing immunization service, but most of the immunization services are being provided in the primary level. And this is also to show you the immunization managerial system, starting from the federal Ministry of Health to the Kabale level, which is the lower administrative level in Ethiopia. Thank you. Next slide. Okay, as you can see here, it is just to use a background of Ethiopian immunization program. As you can see from the slide, the immunization program was launched in 1980, and since then we can introduce a series of vaccines, and now currently we are providing about 12 antigens, and recently, as you all know, COVID-19 were introduced in 2021, and we also provide other antigens for outbreak response that includes yellow fever, meningitis A, cholera, and so on. Next slide. Okay, to show you some policies in Ethiopia, we have health policy and other strategic plans, which includes health sector transformation plan and the comprehensive immunization multi-plan. And again, immunization policy, we have also immunization policy, and it is recently revised in 2021. The one we are going to deal with is the catch-up vaccination guidelines that we recently developed. The other, the national deployment plan for COVID-19 is this one, and cold chain decommissioning guidelines, waste management guidelines, and so on, the other guidelines. Thank you. Next slide. This is just to show you some success of immunization program. We have eradicated wild polio virus, eliminated maternal and neonatal tetanus. We introduced several vaccines to prevent vaccine preventable disease. And as you can see from the slide, based on the WINIC report, the immunization coverage is increasing since 2000. But as you can see from the last point, due to COVID-19 and the conflict in Ethiopia, the pentas coverage shows some decrement. Next slide. As you can see, and Stephen was talking about, WHO defines catch-up vaccination, action of vaccinating an individual by whatever means who misses or has not received doses of vaccines for which they are eligible per the national immunization schedule. The timely vaccination is a key to maintain population immunity as early as possible. So we need to work for that. But if there is a case that miss, we need to vaccinate. We believe that it is always better to vaccinate late than never. Next slide. as it is discussed before my presentation, immunization catch-up vaccination has lots of benefits. The first one, it integrates with other essential health services to strengthen primary health care. The other, address missed opportunities for vaccination, strengthen collaborations with other sectors to engage on immunization efforts. It also indicates strategies to access special population groups like migrants, internally displaced or urban slum populations. It also helped to introduce targeted communication and behavioral interventions to help minimize vaccinations, to also bridge immunity gaps and ultimately reduce reliance on the SI and outbreak response activities. Next slide. Thank you. When we come to the catch-up policy in Ethiopia, just we have developed the catch-up policy or guideline based on the existing challenges we have. We try to develop the catch-up vaccination guideline because the existing policy guidance does not answer the gaps that we have. As you can see, we have lots of unvaccinated children, what we call it zero dose, and there were COVID-19 and conflicts, flooding, and other challenges that disrupt immunization service. And again, you can see that Ethiopia is among the leading countries that is contributing zero dose to the global. Next slide. Yeah, thank you. So to develop this catch-up vaccination guideline, we have used these steps. First, we try to review and gather global and national policy recommendations. Based on that, we try to brief the national high-level leadership defining the scope and the rationale for developing this guideline, and then engagement of national API technical working groups. Here, just we invited to engage all immunization stakeholders, and through the development, they were a part of it. And then we continue to develop the guide with detailed sections, and then we take it, the final version, to endorsement by ICC, which is the final immunization management level that endorses such policy, and then the higher level of the ministry endorsed the catch-up vaccination policy. Next slide. Next slide, please. Thank you. This is just to show the routine immunization schedule. As you can see here, there are vaccines under the routine immunization, and the age is indicated here, and the route of administration indicated. Not to take more time, I can proceed to. It is just based on the global recommendation, so that I can jump to the next slide. Next slide, please. Okay, this is just here. It's the point. The gaps that we have in the routine immunization schedule and other policy labels is going to be answered by this. You can see that this catch-up vaccination schedule have a list of antigens considered in the catch-up vaccination. Then you can see the second column, the total doses, the minimum age for dose one, and the minimum interval between dose is also indicated there, and the upper age limit. The upper age limit were very, very important issue for us, that the previous policy lacks. So as you can see, by the routine immunization policy, most of the antigens except measles second dose were provided under 1 year, but due to the need for to vaccinate the late or the missed one, we take the age to under to up to 24 months for antigens which we are given under to, and for BCG you can see it is expected to be given at birth in the routine immunization, but we extend it to up to 1 year for the catch-up schedule. Then the OPV1, Rota, PCV, I mean the Rota, PCV, Penta, IPV, these are extended to the schedule up to 24 months. For other two vaccines, particularly polio and the measles, we deliberately make them up to 59 months due to their epidemic prone diseases, and they are targeted for elimination and eradication. So we need to work on that. We have risks on that. So we need to extend the ages up to 59 months. These all decisions were made based on the WHO recommendations, Ethiopian EPI policy, local epidemiological outbreak data, and the like. These were decided through extensive and I think series of discussions with all stakeholders. Next slide. Yeah, these are the strategies which used to conduct catch-up vaccination. The first one is we are planning to conduct catch-up vaccination throughout the routine immunization, and we can particularly link with the 2-vial vaccination platform. When the children come to 2-vial, I mean in the second year of life, they will be checked for other the status for other antigens, and they will have a chance to take vaccination for other antigens. The second one is the African Vaccination Week. As you all know, we celebrate each year, and then we use this opportunity to mobilize and identify missed children, so that we will organize catch-up vaccination and conduct the vaccine. The next one is the PIRI one. We will have intensification of routine immunization. So we will have periodically, we will identify and conduct catch-up vaccinations based on the PIRI guideline. The other one is integrative with the supplemental vaccination activities. We conduct supplemental vaccination activities, and that this is an opportunity to strengthen the routine immunization. So during this time, we will use this as an opportunity to identify and vaccinate the missed children. Next slide. Yeah, as a component, you can see that our policy has the planning section, how to plan and organize the vaccination, catch-up vaccination session, and the next one, availing the vaccine and supplies. Where we have also a section on training of health workers. The other, communication, community engagement during the identification and vaccination of the missed children. The other, recording and reporting is the other section, and monitoring and evaluation is also part of that section. Thank you. Next slide. Yeah, this is to show you some examples that we have exercised this. As you may have the information, we have recently conflicts for the last 3 years, and service were interrupted in some regions, or you can call it provinces, in Amhara, Oromia, Afar, and Benshangul. And based on that, we have about 237 IDPs and 5 refugees. In these areas, immunization service and other primary health services were interrupted. Due to that, when we get some time of peace, we try to conduct immunization service, which is integrated measles SI. Actually, it was conducted for under 2 children. And then we use this opportunity to conduct catch-up vaccination, and we were able to vaccinate this amount of, you can see per each antigen, for example, PCG about 38,000 and OPB1 about 46,000 and the like. And you can see the last column, among that 22,000 children were zero dose. Next slide. This is also the recent experience that we have conducted. We conducted a national preventive measles campaign, and we use this opportunity to vaccinate, to conduct integrated with this SI. We conducted catch-up vaccination, and we were able to reach more than you can see per each antigen. And for example, if you take this, the Penta one, we were able to reach 114,000 for 448 children. So you can see that these were late based on the national vaccination schedule, and you can see that this amount of zero dose were we were able to reach such amount of zero doses using this opportunity. Next slide. Okay, having that experiences, we are also experiencing challenges. For example, lack of adequate operational resources, particularly in conflict affected, since there were extended interruption of services. We need to have resources to conduct such vaccination on that area, and the other one, additional vaccine stock for catch-up not allocated during vaccine renewal. As you may know, vaccine renewal were conducted annually, and it was based on the previous performance. Then when you use this chance to use to vaccinate the late the missed children, you need additional vaccine. There are still persistence of conflict and humanitarian emergency in some areas, so that we can't implement catch-up vaccination in that. And the last bullet is the one that we are challenging, the HMIS and monitoring evaluation. Reporting tools not addressed the changes. We need to deal with the MND people to change reporting and recording tools based on the new policy, since we developed the policy recently. Actually, currently what we are doing is just we have registration book routine immunization, and the late doses are recorded then, and we have revised the tally sheet and distributed it. So the reporting will be based on the revised tally sheet, but we don't revise the registers yet. So we are advocating for that. So currently, even the DHIS2 reporting system is not consisting of such catch-up vaccinations, but for the time being, we are using parallel reporters in a separate way. But in the next, we are trying to revise this reporting and the recording tools based on the new policy. Next slide. Okay, so next, what we are planning is just to have fast-track health workers orientation on the new guidance, allocation of extra vaccine and logistics, resource mobilization for conflict affected IDP to conduct the catch-up vaccination, aligned with country strategy to reach zero-dose children. You know, we are currently also developing an action plan for reaching zero-dose children. We have a national. We develop the draft for that, and we need to align with this. Enhance service integration through life course approach. This is also the next action that we want to do. The last one, strengthen demand creation on the importance of timely complete vaccine. You know, we don't want to conduct catch-up vaccination throughout our life. We want to strengthen our immunization system, and so that we can timely vaccinate. So we promote timely vaccination, and finally we hope there will not be application of catch-up vaccination if we achieve once. This is my last slide, I think. Next slide. Yeah, thank you, all of you. So if you have any question, my colleagues Kebrom and Johannes are with me. We can address on that. Thank you.
Thanks a lot, Stephanie.
Thank you so much, Melkamu. That was a really, really interesting presentation. And now, just to keep things moving quickly, I'm going to hand it over to our colleagues from Cote d'Ivoire, Serafin, CA, or if Dr. Fatoumata is on, then over to you.
Ok, merci Stéphanie.
Okay, thank you, Stephanie.
Je suis Kwasi Serafin.
So I work in Ivory Coast, and I am really pleased to introduce what's happening in Ivory Coast. We are going to present our strategy for catch-up vaccination against HPV in Ivory Coast. Next slide. So just to remind you, in Cote d'Ivoire and Ivory Coast, we introduced the vaccine against HPV among routine vaccinations since November 2019 for girls aged 9 with 2 doses every 6 months. And we introduced that thanks to the technical assistance of various partners and the financing from Gavi. We worked with UNICEF, WHO, and Spiegel. But shortly after the introduction of a vaccine, we had the COVID-19 pandemic in March 2022, which required us to define some new barrier measures, such as closing schools, and also started rumors on vaccination. All of that had an impact on the deployment of the vaccine and its operations, especially regarding vaccination against HPV. It was complicated to deploy the vaccine in the context of a pandemic, which had an impact on the vaccine coverage, on the routine vaccine coverage, and especially regarding the HPV vaccination coverage. So in 2020, the vaccine coverage for the first dose was only 4% and 9% for the second dose. So to relaunch vaccination against HPV, the country had to adopt a new strategy and to strengthen planification and coordination. So next slide. So what I wanted to point out here, so what did we notice and what were our strategies, our national strategies? So we performed a data analysis, so this was very clear. And in March 2020, the data analysis showed that 58% of health districts had a coverage that was inferior to 50% of the first dose. And regarding the second dose, 98% of the health districts in the country had vaccination coverage under 50%. So in those districts, when there's a large number of girls that were not vaccinated, the analysis kept going at the level of health centers, so we could identify zones, areas to perform interventions. So then we developed strategies, vaccination strategies with the administration of vaccine, including HPV vaccine, every time there was the occasion to do service delivery in schools and communities, for example. And it's essential for the health center to offer that vaccine, especially because HPV vaccination really struggled to get started because of the COVID pandemics. And so here, no sound. So we have talked with the various people to develop a calendar, a consensual catch-up schedule for all antigens, including HPV up to 14 years of age. The country then introduced a national vaccination campaign against HPV in November 2021 that implied a lot of stakeholders, including the teaching community, so there could be catch-up vaccination in schools, and also so that we could raise finances for the communities. And to this was also added the intensification of vaccination in the community and at school. Next slide. So in this activity, like I said before, it was also important for us to document the strategy, but also to focus on the communication strategy. So regarding the second dose, we were talking on focusing mostly on the quality of data and on documenting vaccination in order to improve data quality, but also so we could perform a better follow-up of essential vaccinations. So at the level of the country, it was important to revise and also adapt the communication strategy so we could face the COVID-19 pandemic, and so we could pass on informations. And we had to see like the vaccine was not dangerous, and the essential elements, we had to show that there was a synergy between the Ministry of Health and the PEV, notably, for example, the university and school programs, the national program of fight against cancer, and other stakeholders in terms of activity planifications towards its routine activities or catch-up activities in terms of planifications and elaboration of a plan. But also in terms of communication. In terms of communication, we have to point out that the country initiated some meetings with the Education Ministry, and we gave a lot of information on HPV vaccination so that the personnel could communicate at the level of school that vaccination and also to communicate about vaccination at the level of schools. This contributed a lot to vaccinating in the context of COVID, but also we had to implement a lot of activities with various stakeholders, and we had to forward essential information regarding these catch-up activities. So we had to talk and train about all stakeholders so that we could highlight all the results and the challenges in order to define better strategies to vaccinate. We had also some additional strategies. So looking at people who were under-vaccinated or missed vaccinations in coordination with teachers. So we could target the girls who going to school. We also integrated vaccination against HPV in the systematic medical school visits. And these are organized every year. And these visits, these medical consultations at school give us the opportunity to catch up with all the girls who missed out on the vaccination. Also, so that we could meet demands, we had to really focus on the vaccine stocks so we could cover the demand. Next slides, please. So what results did we record in 2021? Thanks to the vaccination campaign that was organized at the national level, the first vaccination dose against HPV, we had cover that's really improved, and only 10 districts had coverage that was inferior to 50%. So for the second dose, despite the campaign, the coverage remained quite low, around 7% for the second dose, and we have to look at the level of the country. Almost 90 health districts recorded health coverage that was under 50%. And 4 only had a coverage that was between 80 and 95%, and only 1 district has a coverage over 95%. Next slide, please. So for 2022, the country didn't organize a campaign because campaigns are very expensive, but there was a periodic intensification that was organized in some districts to target girls that were unvaccinated or under-vaccinated, and the strategy on top of routine vaccination allowed Ivory Coast to have coverage for the first dose at over 64%. So we can see only 32 districts had a coverage inferior to 50%. 18 districts had a coverage being 94%. And for the second dose, comparatively, in 2021, there was a progression of 20%. So it went from 7 to 27%, but we can notice there's a disparity still, and we need to take action so we can improve vaccination, the second dose vaccination with catch-up vaccination. Next slide, please. So like I was saying earlier, there were a few strategies that the country implemented in order to improve vaccination coverage against HPV, but there are still some challenges, especially catch-up vaccination for the girls who do not go to school and who live in the community. So we need to use strategies to put them into place so that these girls who do not go to school can beneficiate from vaccinations through community interventions. But also, there's the question of continuously updating their health services and the health centers on the notion of infections, HPV infections, and preventing the measures. This would contribute to communication and should contribute to prevent some vaccine infections. Also, at the level of the country, despite many strategies, the coverage has remained low, with under 50% of people vaccinated with a second dose. It is therefore very essential to implement a strategy. Next slide. So lessons learned. First lesson that we learned: we need to engage the stakeholders from the beginning of the planification, which contributed a lot to the success of the activity, especially through catch-up vaccination. It's also very important to engage stakeholders in routine vaccinations. This is a very essential activity, especially because we need to communicate. We need to use trickle communication in the education community, which will contribute more easily to engagement and adopting new behaviors regarding HPV vaccinations. We need to use pair communication, especially at the level of school health centers. We need to take advantage of the systematic medical consultations at school, which will contribute to promoting and optimizing the service offer. We also really need to periodically intensify the systematic vaccination against HPV in order to improve vaccination coverage. And even though we need to keep including in-routine vaccination, but we can see with Cote d'Ivoire, Ivory Coast, in our experience, intensifying really helped improving vaccination coverage at the level of the district. Next slide, please. So regarding the challenges, especially around the second dose, we are currently thinking with stakeholders at the level of the country so we can develop some strategies that will improve the HPV vaccination cover and also improve it for other antigens so we can include it in routine vaccinations. We also need to work with the National Committee of Independent Experts to think about the adoption or not adopting vaccination schedule, just one dose vaccination schedule against HPV. On those words, I'd like to thank you. And if you have any questions, we will try to answer them. Thank you very much.
Merci, Séraphin. Thank you very much. Stephanie, the floor is yours.
Thank you so much to all of our presenters, and I appreciate that we actually only have very few minutes left for Q&A, and so I was encouraging my co-presenters to respond to the questions in the chat as we went in case we didn't have enough time. So if you put one into the Q&A, please check if you've gotten a longer response there. Since we do still have a few minutes, we can address a couple of them live. So one was addressed to me, and I'll just quickly respond to that for the benefit of the rest on the call, and then we can turn one over to Ethiopia. So somebody asked, just to clarify that an integrated catch-up vaccination in a campaign mode is different than a country having a catch-up policy for missed doses and routine immunization services. And to please clarify that. And so absolutely, that's true. Delivering catch-up in an integrated campaign mode is one strategy to address a large immunity gap that might have built up, for example, as we've seen in recent years over the pandemic, or just to reach a large group of children or adults in a quick way. Sort of similar logic as to why you would have a vaccination campaign in general, an SIA. But it's only one strategy that should always be done in addition to having the opportunities for catch-up vaccination through the routine program at any time anybody visits a health facility. So this is just applying the missed opportunities for vaccination principles, whereby if a child or an individual comes in for another service, a different vaccination appointment or a medical checkup or a well child visit, implementing a practice whereby the health worker can check the vaccine records that they have, see if they're missing out on any doses, and providing that opportunity for catch-up on site at that time is what we really want to be seeing happening. And that can happen in addition to some of these additional strategies. So hopefully that explains that a little bit better. And I think we have time for maybe one or two more questions. So there was a question for Ethiopia around the vaccine stock issue. And so maybe if I can just turn that over to Kibram to reply in plenary, because I know that question comes up a lot, and that will also be handled differently if you're doing it in an integrated campaign mode where you need a large amount of supply at one time, or if you're just doing it through the routine system, whereby you really should be able to kind of manage that slight surge just through the buffer stock and having, as I mentioned, an agile vaccine forecasting system where you can, continuously update your needs accordingly. But I'm interested to hear how that was handled in Ethiopia. So over to Kibram, if you wouldn't mind.
Okay, thank you so much, the questions. Yeah, as Balkamo tried to address and to mention on his presentation, this is a critical issue, and we have recently been discussing with Gavi during the annual vaccine renewal to address the needs for extra dose in addressing the missed doses. But up to now, we have not have any major challenge because we are only targeting conflict and conflict-affected areas, humanitarian affected emergency settings. In those areas, we have tried to address the vaccine stocks based on their annual consumption allocations. So with that, we try to manage. But for the future, we are flagging it and keep discussing with Gavi to address the extra dose needs, and which will be in line with zero dose, the strategy and action plan that the country is committed. So that is my reflection. Thank you, Stephanie.
Thank you, Kibram. And because we have 1 minute, I want to provide Cote d'Ivoire with an opportunity as well. There's a question, what was the single most effective aspect of catch-up for HPV, recognizing that there are continued barriers, but if you could identify the single most effective or at least one. Sarah, would you be able to take that question?
Ok, merci. Comme mentionné dans la présentation,
Oh, sorry,
dans la
Sarah.
vaccination de rattrapage, ce qui a beaucoup marché.
Would you be able to just answer this in English, just because we need to keep this session in English for recording purposes?
Vous m'entendez?
No, c'est pas de
Are you
problème.
okay?
No,
Okay,
no
merci.
problem. No problem. He can speak
In
French.
English. Okay. I would like to
Then go
mention
ahead.
that the essential point during catch-up vaccination is very strengthening of coordination at all level, and that leads the implication of the stakeholders, especially teachers in schools, and they communicated on HPV vaccine in school, and the other point of the integration of HPV vaccine during service or delivery in a school steps.
Merci, Sarah. So I think that that's the end of our time. Unfortunately, we have to end, but please refer to the Q&A to see the other responses, and we'll be able to share all of this, the recordings, the presentations afterwards. I also just want to add quickly before you all leave that our next session in this webinar series will be happening on April 19th. And that is going to be a session on integrating COVID-19 vaccine with other routine services and primary health care. So additional communication will go out about that, but if you've registered for this one, you will be automatically registered for that one as well. But please do continue to share the links within your networks and encourage colleagues to join. And if you have any additional follow-up questions for us or any of the presenters, all of the emails are available in this presentation. And so you'll be able to reach out to us and do feel free, because I know we didn't have as much time for Q&A as we hoped, but lots of stuff to cover in a short amount of time. So thank you all for your engagement. Alex, do you have anything else to add?
No, thank you. I think you said everything. So we can close this session, and we'll send final reminder, but you already said it. We're going to send everything by email, recordings and everything. And I think you received an email today from me about the webpage where you can find all the materials anyway. So you can just refer to this webpage at any point. Thank you, everyone, and have a wonderful rest of the day.
Hi, everyone.
Bye. Au revoir.
Thank you, everyone. Have a nice time.